Thank you and good morning. How, in fact, do you actually follow all of that? Really overwhelming and amazing accounts from these two heroic people. It is very true that in the past 20 years, there has not been the level of change that is necessary to bring about accountability, to bring about sustainable culture change, to bring about improvement. Governance and accountability both call for a brand of leadership that clearly articulates its commitment on the one hand, and then demonstrates its resolve to see that commitment realized in the operationalization of its business model. Our healthcare leaders continue to craft really eloquent mission and vision statements to describe the domains of professionalism, to deliver exhortations about being open, honest with patients in the aftermath of adverse events. But there is a huge mismatch between all of that and the lived experience of many patients in this country. Media coverage, together with the very personal accounts you have heard from Vicky and Stephen, can really only serve to expose the shameful degree to which Irish healthcare has repeatedly failed its raison d'etre. And what is the raison d'etre of our healthcare system? It is the patient in the bed. It is the family. It is the people who entrust both their own welfare and that of their loved ones to individual professionals who populate the system. And above all, we entrust ourselves to the quality improvement strategies which should drive that very system. But is all of that happening? The current healthcare reality does drive patients and families reluctantly into the arms of a litigation process, while also demonizing them for having taken that route, when healthcare itself has not stepped up to the plate and been honest and open in addressing their legitimate concerns and in answering their questions relating to how those adverse events occurred in the first place. And then it dismisses their call for an indication of what will change to prevent recurrence in the future. The human rights activist James Baldwin, sorry, I have made a mess of this, haven't I? Yes, James Baldwin, the human rights activist, tells us that not everything that is faced will change, but nothing will change until it's faced. How good are we at facing the reality? Do we allow ourselves be captured by spin and wanting to present things as we would like them to be, rather than they actually are? The deny and defend at all cost strategy has resulted and has spawned the patient advocate. People like Vicky, people like Stephen, people like myself. As WHO Patients for Patient Safety champions, our group, we're not career advocates. We are volunteers. We're committed to being collaborative partners and co-producers of safe care. Circumstances have brought us to the work. We haven't chosen this work for ourselves. Rather, it is a responsibility which has been thrust upon us, one which we gladly forfeit for the restoration of the lives and well-being of our loved ones who have been harmed by healthcare, albeit unintentionally. We strive to have these experiences become some kind of catalyst for change in an improved health service. We accept that we cannot change the past. I, for one, would dearly love to be able to change the past, but I'm intelligent enough to know that I can't do that. But what we want to happen is that we would use the past to inform the present, and then in the present, we can influence a better future. And isn't it so much better if we do that together in partnership? a kind of partnership that can be summarised as empowerment of patients and families by enablers in the system. And that's what we're asking our healthcare leaders to be, such enablers. What is there about that word change that causes such resistance? Why are highly educated and professional people so averse to change and remain committed to the viewpoint, which is often articulated as, oh, this is how it's always done around here? On the other hand, I've also met countless staff who want to do the right thing in the aftermath of an event, but they're fearful of putting their heads above the parapet. Because what happens when you put your head above the parapet? It gets shot off. But where are the visionaries who will change all that? I have been questioned at conferences by people saying, but Margaret, you want us to give information to patients which they can then use against us. Now, there's something very toxic in a system which creates those kind of anxieties. The Medical Council itself, and I've just finished 2 consecutive terms on that council, conducted a survey of public perception of the different professions. Over 90% of the respondents said they trust their doctors to tell the truth. Isn't it then all the more unacceptable when that high level of trust can sometimes be betrayed? The preferred commitment says we will proactively engage patients in their own care. We will capture in every way possible the lessons to be learned from the rise and death of our healthcare and their experience. And over and above that, we will embed patient and family into every aspect of our organisation's activities. We can then deliver a framework such as that described by the Commission. And Gabriel Scally sat on that commission and helped craft that framework, which is worded as knowledgeable patients receiving safe and effective care from skilled professionals in appropriate environments and with assessed outcomes. When making the case for engagement, we are supported by such things as the report Safety First 2006, which says that around the world, those healthcare organisations that are most successful in improving safety are those that encourage close cooperation with patients and their families. And we do need to remember a very important fact. The patient is the one entity that is present throughout the full continuum of care. And undoubtedly, he's also the individual with the greatest vested interest in the outcome. Sure, there will be challenges, and I've heard Jim Conway, Senior Vice President of the Institute of Healthcare Improvement in the United States, talk about making the status quo uncomfortable while making the future attractive. And I really like that. And maybe that's what we should be asking our leaders to do, to engage in making the status quo uncomfortable so that we will have a better future. And Vicky and Stephen and people like myself, I think we've come to a point where we kind of consider ourselves a little bit like that piece of grit in the oyster, causing sufficient irritation to bring about the pearl. And in this case, the pearl could be that of healthcare improvement. But where do I, Margaret Murphy, fit into all of this? Well, like many others, I've undertaken advocacy work because of a negative experience of healthcare, the needless death of my own 21-year-old son, Kevin. And 2 aspects of that experience have influenced my resolve. One was that every point of contact in the Irish healthcare system failed Kevin. And secondly, that injury was then further compounded by the very real fact that learning opportunities were frustrated by damage limitation efforts after his death. And I would contend that the duty of care to a patient doesn't end with the death of that patient. Adverse events happen to real people, and the consequences are far-reaching. Kevin was more than a statistic. He was more than a medical condition. He was a young man in his early years at 3rd level. Could be a challenging young man. He could certainly push all my buttons. He could make me laugh, he could make me cry, he could make me proud of him, he could make me disappointed in him. But more than anything else, he was my beautiful boy, handsome, strong, and carefree. He deserved a better patient journey than that which was later described as a manifestation of Jim Reason's Swiss cheese model, in that every point of contact failed him. The failings and shortcomings were serious. They were many in number. As I say, they were serious in nature. They were indicative of system breakdown, compounded by misdiagnosis, inappropriate treatment and management, together with issues of communication and data handling. Laboratory results were mishandled. Those tests providing sufficient data, which if interpreted correctly and acted upon promptly, would most certainly have saved his life. And those errors range from his treatment at primary care level right through to that afforded him in a tertiary training hospital. All of it happening in the last year of the millennium in a first world country. Not what we would expect. And made particularly unacceptable when research tells us that the procedure to address his condition has a 96% success rate with a 1% complication rate. And reviewers later saying things like, all the evidence indicates that the patient was suffering from a solitary parathyroid adenoma at the time. Removal would have been curative with a normal life expectancy. But what about the aftermath of an adverse event? How does that play out? Yes, there were initial honest and humane reactions from individuals, and I'll always be grateful for that, in particular the nurse. I remember her sitting at the bedside with me immediately after his death. She was crying as freely as I was, she was rubbing my arm. And I turned to her and I said, "But don't you see this every day?" We were in ICU. But that woman was quite emphatic. Quite crossly, she said, "Oh no, that should never have happened." And to my dying day, I'll be so grateful to her for her naked honesty. But in a very short space of time, that was replaced by corporate damage limitation. By and large, we were faced with defensiveness, closing ranks, lame excuses, and a general mudding of the waters, while we were craving for an honest and open encounter with the professions and the system and answers to our very simple questions. How can a young man go to hospital on Thursday and be dead on Sunday? What went wrong? We need to know. We need to understand. Can you please help us with that? There was no evidence of a resolve to prevent recurrence by firstly acknowledging the errors and then engaging and reporting and learning in order to prevent recurrence. In the process, compassion, open disclosure, a duty of candour were all sacrificed on the altar of corporate damage limitation, and improvement measures were lost. For example, at a significant point in his care, crucial blood tests were phoned to the GP surgery. They were written on this post-it note by the practice nurse. His calcium levels are now at 5.73 in a normal range of 2.05 to 2.75 millimoles a litre. He's gone off the Richter scale. Alarm bells should have been clanging like Billio. But when writing the letter of referral, the GP only included in that letter the elements of the blood test results which supported his own diagnosis of leptospirosis and omitted any reference at all to the calcium reading. He filtered the test results. Matters were further complicated, and as a matter of fact, we later learned that he had experienced some success in diagnosing leptospirosis in a number of people. So here he is, thinking I now have another notch on my gun. Confirmation bias, and not thinking beyond that. Matters were further complicated by the fact that when compiling the file in the hospital, because you're talking about a small piece of paper, a post-it note, they didn't want that lost. Somebody had the bright idea to stick it to the back of the referral letter. And as a consequence, it wasn't seen until 6 weeks after Kevin's death. You know the expression, a life hanging on a thread? At this point, Kevin's life was hanging on a post-it note. Last year of the millennium in a first world country. At a meeting in the hospital where Kevin died, the head of department suggested that even if that post-it had been seen by his consultant colleague, it would not have meant anything to him. And of course I was curious and I said, why do you say that? And he said, it's not written as we write it. So I said, can I see it? And when I looked at it, I said to him, are you saying that it wouldn't mean anything to you because it's not written in scientific notation? And the man said yes. A suggestion that Cl might not mean calcium, POT might not mean potassium, SOD might not mean sodium, and they all in each other's company. It was at that point that I lost faith as I identified two things. It was a very thinly veiled attempt to put some level of blame on the nurse, which I didn't like. And I also identified a reluctance to be open and honest. And our hope of, if you like, ascertaining the truth through honest dialogue was shattered, and that's why we undertook litigation. 5 years later, a judge of the High Court declared it is very clear to me that Kevin Murphy should not have died. 2 GPs, a private consultant, a hospital consultant, and a hospital all admitted liability, expressed their regret at his death, and sympathised with us as a family. Something which could have been done within weeks, if not days, after his death. All the focus was on defending a lawsuit rather than identifying improvement measures. Those apologies were made by legal representatives, not in person, so the ownership of those apologies is certainly fragile. Monetary compensation was never an issue for us as a family because the sum of money in my book doesn't even exist that would equate to my Kevin. I can't think of such a figure. Neither could we imagine any circumstances in which we would derive benefit or pleasure from such money. So ever before our case went forward, we signed off any future settlement, should there be one, to 2 charities, Boher and the Make-A-Wish Foundation. I'm totally convinced that proper disclosure and dialogue with us as a family would have been far more beneficial. The trustworthiness of systems and individuals is certainly most severely tested in the aftermath of an event, in how disclosure, transparency, and open disclosure are played out. I'm convinced that disclosure is not about blame, it's not about accepting blame, it's not about apportioning blame. Rather, it is about integrity, and it is about being truly professional. It's about learning and preventing recurrence. The international experience dispels the myth that mandatory disclosure will result in all kinds of unintended consequences. We only have to consider the Michigan experience, where a full disclosure policy was adopted back in 2002. They moved from deny and defend to apologise, explain and learn when wrong, and to vigorously defend when right, and then to view court as a last resort. Their audit of the impact of their decision showed that their ratio of litigated cases reduced from 65% to 27%, their average claims processing time reduced from 20.3 months to 8 months, their insurance reserves reduced by more than 2/3, their average litigation costs more than halved, and then what did they do? They channeled all those savings into patient safety improvement initiatives. Could you ask for anything better? In addition to it being a moral case, it's also a very sound business case. The UK legislated for their duty of candour in 2014, and anecdotally, we're hearing that it is having a positive effect on changing culture. There's no evidence of those unintended consequences, and all the major organisations are now accepting of that statutory duty, and it's one of the fundamental standards for health and social care providers and is underpinned by the Quality Care Commission regulations. Scotland has passed the necessary legislation. Wales and Northern Ireland have signalled the intention to do the same. Disclosure is considered by those to complement the professional duties doctors and nurses are under, and ensures that obstacles are not put in the way of what good professionals really want to do. So should you remain sceptical, I will come close to finishing with a lovely story from the US. It's the story of Dr. Rick Van Pelt and Linda Kenny. He made the error. She flatlined. He in college was known as Iceman, so you know the kind of individual we're talking about. But he connected with a part of himself that up to then he didn't know existed. And he badly wanted to speak with her, to explain to her, and to have that important, powerful conversation. Hospital said no, insurers said no, colleagues said no. He went with that for a while, and eventually he said, I can't take it anymore, I have to meet this woman. And yes, they met, and it was a difficult meeting. The doctor and the woman he almost killed. But he says, with great relief, that on that day, an 800-pound gorilla got off my back. Now that's some image. An 800-pound gorilla on your back 24/7, and you can get shut of it by having a decent conversation with another human being. Sadly, oh, and another thing, they actually went on then together, they did work together, and they set up the organization MITSS, Medically Induced Trauma Support Services, which supports patient, family, and clinician when things go wrong. And I've seen them jointly present at conferences, and they're an absolute wonder to behold. Insensitive responses to families create new patients. The trauma arising from how we are received can often be more damaging than the event itself. In conclusion, I do want to emphasize a number of things. My call for care that is delivered in accordance with the British Medical Association motto, which says, with head, with heart, with hand. You need the three elements. You need the intellect, you need the skill, and you need the compassion piece. My call for reporting and learning. My call for transparency, accountability, open disclosure. My call for patient engagement and involvement as a human right. All of those exhortations are grounded in one very real fact. I was present at Kevin's birth. I'm his mum. I know every detail of that birth. I was also present when he died. And as his mother, I needed and I deserved to know everything about the circumstances which brought that about. And over and above that, I needed to be assured that lessons would be learned, that the lessons would be disseminated, all in the hope of preventing recurrence. For as Sir Liam Donaldson, chair of the World Alliance, says, to err is human, to cover up is unforgivable, but to refuse to learn is truly inexcusable. So thank you.